So when we do not have nurses at this table, when we actually exclude them from these conversations, we are actually creating a system that does not actually cognitively recognize the inherent purpose and importance that nurses have within these segments. And it is almost backwards that there would ever be a table where nurses would not be present or actually participating in those conversations.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this week's episode, we are speaking with Rebecca Love, Chief Clinical Officer at IntelyCare, and we are going to talk about the state of nursing, or as Rebecca puts it every time she posts on LinkedIn, #state of nursing. And she is a powerful voice and a strong advocate for nursing care. And Chris, there is so much that is going to be packed into this conversation. You will leave with your mind blown, but it's going to be worth it.
Let's do it. I'm ready. Let's get on the roller coaster.
Stay tuned. We'll be right back with Rebecca Love.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Rebecca Love, Chief Clinical Officer at IntelyCare. Rebecca has also co-authored 2 books. She's founded 3 companies. She speaks internationally, and she is dedicated and passionate about empowering nurses to be at the forefront of healthcare innovation and entrepreneurship. Rebecca, thank you so much for speaking with us today. It is really an honor to have you on the show.
Melanie, Chris, I'm thrilled to be here. So thank you for having me.
Oh, absolutely. You know, I first heard about you through a fellow nurse, and she said, "Hey, are you following Rebecca on LinkedIn? Because you need to be." And, you know, I was reading all this stuff that you have posted and written about the state of nursing and, you know, learning more about the commission that you're spearheading. And I mean, we're going to dive into all of that today. But before we do, why don't you just introduce yourself to our audience and tell everybody a little bit about you?
Well, thanks, Melanie. So by training, I am a nurse. I was a nurse practitioner for over a decade, but I really was a person that loved to find problems that needed solutions, or actually take action on problems that needed solutions. And I think that is something slightly different than what we were taught as nurses. Is we were taught to identify problems, but really we were taught to come in and just manage the tasks that we were given. So I felt like often as nursing, we continued to live the definition of insanity, going into environments that were not sustainable, and nobody gave us the power to fix them. So my whole life since those moments of starting my own companies really was about the idea of building hackathons and creating places where nurses can innovate and solve the problems that really drive them crazy at the bedside and beyond, and really scale and empower the nursing workforce to have a voice that transforms the future of healthcare. So that's where I spend much of my time living, breathing, and dreaming.
Well, that's a good place to spend it, because you're right. I feel like we often just get handed the hot mess and they're like, okay, just drive the hot mess express and deal with the problems. But we don't have the solutions coming from the back end to solve it in the first place, you know?
Totally. And I think that's and I think you guys know this, right? It's so often as nurses, we were at the end where people would come in and they say, "Hey, you know what? We're solving this problem for you." And you'd be like, "Well, I don't think that's really the problem we're having." And then they'd say, "But you know what? Actually, this device or this process is going to make less work for you." And we would sit there and we'd be like, no, that actually created more work for us. Yeah. And I think the last 10 years in healthcare has been this trial and experiment of a whole bunch of new technologies, a lot of private equity, a lot of venture capital money coming in and forcing new ways of what they think is solving a problem in healthcare, which really was about making more money. So really didn't do anything that drove better outcomes necessarily for patients or for nurses. As we know, you guys, healthcare is more expensive than ever for patients across this country. Yeah. Outcomes are actually worse than historically and comparatively to pretty much any other nation in the world. And the question has become, we've given so much extra work to nurses without trimming back any of the work that they did, that we are burning out and losing this workforce at numbers and rates that we've never seen before in history. And to me, that is something that is critically important to why we're having this conversation.
So I also think that it extends beyond just the field of nursing. I think there are so many other like health science and the supportive professions, if you will, in healthcare, where it's that people are making decisions about what could or could not help your workflow, but the people who are actually doing the work don't have a seat at the table. So there's that disconnect between, what they think is happening and what's actually happening. How do you think you all should, advocate for a seat at the decision-making table?
Yeah, Melanie, I'll start off and then I would love to get your opinion on this as well. I think the reality is that how we actually can navigate this space so that the front line, those staff, everybody from nurses to CNAs to respiratory therapists, OT, PT, even surgeons and physicians should have a seat at the table, is that the reality is that we have such a disconnect between the administrators and the executives in the front line that they've taken away the strategy of operations from the front line and put it squarely into these executive suites. So the decision makers are nowhere near the front line, and the people that are actually driving all of the impact to actual patient care are on the front line. And the truth is we have to resolve that. We've actually worsened the environment. And until we start bringing those individuals who are on the front line, those who are actually managing the direct correlation of care, that the truth is that the solutions that are being brought forward or put forward actually are not advancing the outcomes that we want to have in healthcare. So in my opinion, at this point in time, I think boards of directors of hospitals now have to look at, and should 50% of all boards of hospitals be required to have 50% of them made up of nurses, doctors, or frontline staff that actually represent those? Do we need to get the federal government to start mandating specific roundtables that actually bring in the front line into having those national discussions? And I think more importantly, we as a profession, in nursing specifically, need to start learning the language of the business of healthcare and actually being able to translate, because that is a barrier we're not taught. And physicians do actually have a pathway for this. Well, they'll be sent to an advanced executive coaching or MBA program. Nurses, though, have never had actually that opportunity. And to me, combining an RN with an MBA is going to be a degree program that I think will be unstoppable for nurses to achieve that kind of direction going forward that would allow them more of a seat at the table. But Melanie, some thoughts on your perspective too?
No, I 100% agree, because if we come to the table, we have to be able to speak in a way that the other people at the table can listen, they can understand, and then they can recognize that what we're saying is important, but they can also connect with it and really feel that, okay, this is what they're saying and this is how we can work together to solve it. One thing also, especially in perioperative services, we have different certifications for our scrub techs and for our nurses, and a lot of nurses in the operating room look to their CNOR, their certified nurse in the operating room, as like the creme de la creme of their certification. And it is a hard and well-earned certification for sure, but it's a clinical certification. It is not a business certification. There is a different one, the Certified Surgical Services Manager. That certification gives you that information, that training, that recognition that you can understand surgery from the business level. You can have those conversations with your CFO, with your CNO, your CEO that say, hey, here's what's going on. Here's how we need to fix it. And it gives you that validation that you understand what's going on the business side. And I think it's so important to be able to have that backup that says, hey, I understand what's going on. I understand it from the non-clinical side, all the business sides of it, and we can have a conversation on the same level.
I would agree with that. And I think that if you're looking right now also, there's some numerous problems, and Chris, please jump in on here as well, is that the reality is currently within the state of healthcare. One thing that I don't think is a clear understanding, when I'm specifically around nursing, is that without nurses, there is no healthcare. And what I mean by that is hospitals and nursing homes. The reason patients go and are in those places, why they're admitted, is their lives are so at risk that without 24/7 monitoring and care by a nurse, they could die. Now, everything else could be done outpatient, OT, PT, respiratory therapy, surgery, all of that could be done outpatient. But the reality is that the reason hospitals and nursing homes exist are so that patients can have direct care by nurses, which is a direct correlation, if not causation, of the ability for patients to survive the treatments that they actually obtain. So when we do not have nurses at this table, when we actually exclude them from these conversations, we are actually creating a system that does not actually cognitively recognize the inherent purpose and importance that nurses have within these segments. And it is almost backwards that there would ever be a table at where nurses would not be present or actually participating in those conversations.
Yeah. And I think it's really important that it's the ones that are on the front lines are the ones that are having that voice and being able to speak to the issues, not the ones, not just the ones in higher leadership roles. And anybody, even in the allied health professions, all of us, if we're on the front lines, we should be having a say in it and having a voice in the decisions that are made.
Well, I think that it's a matter of training. We've been talking this entire season about advocacy, right? See something, say something, advocate for your patient, advocate for your profession, advocate for, the processes that you think are actually going to make a difference. But we have to break it down to a smaller bite-sized kind of format, if you will. We have to teach people how to do that. How to speak the language of administrators. I know when I transitioned from the clinical setting into education, that's a whole different language to try to be able to speak so that you can, I guess, really be able to voice your concerns in a format and using verbiage that the other party is going to understand. And I think it's the same thing, right? Because when we transition from speaking about our clinical role to speaking to an administrative ear, you have to be able to speak in ways that they're going to understand what your needs are. That doesn't come naturally. So we have to be able to provide that training as well. And when you already have a profession that's overworked, right, that your patient to nurse care ratios are out of this world, where are you going to find the time to also then develop those skills? It's very hard, don't you think?
Well, I think it's absolutely critical. And I think the truth is that nursing education has largely trained everybody to teach to the test, right? The NCLEX. And so those skill sets were supposed to be designed to help people be proficient in clinically managing patients at the bedside to keep them alive. But what as healthcare is sort of transformed, and it's the business of healthcare, the reality is those necessary languages that we need to understand, operations, strategy, finance, managing a profit and loss kind of statement, are sort of critically necessary for you to be able to advocate for your profession and also the things that you need within your floor to be able to function. So if you are a nurse or a nurse manager and you want to advocate for more staff without being able to speak to the financial impact or the outcomes of the patients, that likely is going to fall on deaf ears. So we as nurses were traditionally taught language around, I think, I feel, I believe. And we know how effective when you go to your CFO and say, I really believe that if we did this, I think if we did this, that this would lead to a positive outcome. We know that that is not something sustainable for the organization. So, and I think something more critical that we should also talk about here just for a second is there's over 5 million nurses in the United States, more nurses than ever before in history. But the challenge that we've just seen actually is that prior to the pandemic, the average length of experience on a 12-hour shift used to be 6 years of experience on a nurse, and it's now dropped down to 2.7 years of experience. The lowest amount of experience ever on a 12-hour shift is recorded in the United States, and that population is getting younger. Our older nurses are leaving the bedside, and for good reasons. But the truth is the majority of our nurses that are practicing are relatively novice within their careers and within it. But scary things that are also showing is that they are churning and burning at very fast rates as well. So prior to the pandemic, 57% of new grads left the bedside within 2 years of practice. And we're thinking it is as high as 70% is leaving the bedside within 2 years of practice. But the interesting thing is that we think, okay, let's just produce more nurses. We graduate 185,000 nurses a year, the largest segment of any graduating population of any degree in the United States. It's not a system of actually graduating more. It's a system of retaining them. But we just are burning at both ends. The new grads are not staying. Our experienced nurses are not staying. And the reality is what we can certainly, I would think, conclude from that is that those who have been controlling the narrative, have been controlling the conversation, their models and their solutions are failing, right? They're failing at scale. So the truth is that we must start engaging with the nursing workforce to solve this, because clearly those who have been assessing and making the changes to date are largely failing at scale. And it's time that we bring nurses to have those tables. But Melanie and Chris, what are you guys thinking?
Well, I actually want to draw on an article that you shared with me when we talked prior to this interview. And it's an article that you shared, and the article is just titled, "Is There a Nursing Shortage in the United States?" And it depends on who you ask. And I'm curious your thoughts on that article, because the article discusses a difference between a nurse shortage and a shortage of nursing care. So how do you think hospitals are going to be able to bridge this gap and provide adequate staffing to ensure patient safety and quality of care while considering their nurses at the same time?
Yeah, Melanie, you're referring to the article that was largely produced under STAT and was largely supported by evidence and research provided by Linda Aiken, one of the leading, if not the leading researcher out of the University of Pennsylvania to study the nursing workforce dynamics. And the argument has long been made by nurses around the country that there is not a shortage of nurses in this country. There's a shortage of nurses willing to work in the healthcare environments as they are today, largely related to being unsafe of practicing because, as Chris had mentioned earlier, nurse-to-patient ratios have made it so difficult to practice that nurses know that they are not able to provide the care that they would like to on patients. Now, let me give a very simple example of how to explain this, which is imagine that you walk into a restaurant. Your waitress has 1 to 6 tables. Suddenly, they have 1 to 8 tables, and then they're up to 1 to 12 tables. We know that things are going to be missed. Orders are going to be given wrong. Things are going to happen. This is what we're facing in the nursing workforce, which currently is nurses are saying, and if actually you look back at the number of strikes that have happened over the course of the last year, from Minnesota to New York to Kaiser, the issue that they agreed on early was pay. But the nurses still walked out and continued to strike because they could not come to an agreement on ratios. Nurses are saying, I want to be able to practice, but the truth is you are not creating environments that make it safe for me to practice. And not only is it not safe for them to practice, we always knew that as nurses, if we made a mistake, we could lose our license, we could pay a fine, we could lose our job and our livelihood. But I don't think any of us ever assumed that as a nurse, if we were working in our best interest and we made a mistake and it resulted in harm, that we could be criminally prosecuted.
Go to jail.
Mm-hmm. But that is exactly what has started to happen ever since the Radon DeVot trial in March 2022. And I think what nurses are starting to realize is I may love being a nurse, but the truth is you've made it too unsafe for me to practice. And I can't choose between my family and my freedom and a failing environment of patients that I would love to care for because you've made me responsible for everything that happens there, but give me none of the power to change or control that environment so I can do my job. And that is what is happening today.
I completely agree. And I also think that it's another example of how two people are seeing a situation completely different, right? Like the hospitals are saying, okay, we'll give you more money, right? But more money isn't going to allow you to make less mistakes or to spend more time per patient when it comes to those ratios that you all are needing. And it's about quality versus quantity. But, you know, we have both Melanie and I are an operating room background, right? And how many times have you heard like time is money? Turnover is usually the big gap, right? Like the shorter the turnover, the faster we get people into the operating room and, you know, the more cases we can do throughout the day, yada, yada. And it's the same thing for whether you're on floor work or whether you're in one of our specialized units. You know, you cannot, I think, substitute quality for quantity when it comes to patient care because it sends attention to details that are going to prevent those lawsuits that eventually the hospital systems are thinking about it. That's a larger financial impact, right, in this litigious society than it is just to maybe hire a few more people and lower those care ratios.
Well, and I think, but I think there's a nuance there that needs to be understood. Is the truth is that to the hospitals, actually, that is not the risk. They don't carry on. In fact, most hospitals will actually drop the nurse from being able to defend them on any criminal cases. That is an independent cost directly to the nurse. The systems do not pay to defend the nurse in criminal ones because they are found to have been guilty for not following process and procedure. So hospitals, to them, they're like, okay, so what? So we staff you short. You get hit with a criminal file. Actually, we're not paying that, right? Like, there's no risk to us. That's the risk on the back of the nurse. And what nurses don't know, though, is that their medical malpractice insurance does not cover them for criminal prosecution. So in the situation with RaDonda Vaught, her trial and attorney's fees cost her out of pocket over $250,000 to defend herself.
Good grief. Who has that?
No nurse has that.
No
nurse has that. So these are the things that people aren't talking about. And these are the things that nurses are burdening. And if we don't think that that's not impacting the collective psyche of the nursing workforce at scale, it absolutely is. What we have done is we've made the nurse completely responsible for all of the failures in healthcare and continue to burden them and make them look, and let's be very honest, let's look at the situation currently going on with the nurses on strike at the Robert Wood Johnson Hospital. They've pulled the health insurance not only from the nurses on strike, but across the entire system. They take punitive actions to further disrupt and erode the nursing workforces in which have supported them and made them to appear to be the ones that are doing the wrong when they are trying to do what's right for patients. And this is a kind of MO, this is the kind of talk track that we must be changing in the overall perception of the public. Because the truth is we should all be always standing by the nurse. There should never be any doubt that if nurses are telling you that something is wrong, that every single person in America should be standing by the nurse. Because if you're choosing between nurses and corporate executives, you have to wonder what is of the interest of that outcome. And I have to tell you, I have never met a nurse who has ever done anything other than trying to represent and protect patients. Now, I can tell you, I sit in a lot of corporate executive rooms, and I can tell you the conversations around patients versus profits, the conversation of profit is always 99% the conversation that occurs. That is never the situation when I work with nurses. The conversation is never about profit. It's always about the patient.
You know, that's actually something that was very, I guess maybe is disillusioning a word? Well, I'm going to make it one, but it was very,
you've coined it,
disillusioning to me when I moved from the front line into leadership. And I was working in my first foray into this, I was working at a for-profit physician-owned facility. And the conversations in the boardroom were not patient-centered. They were profit-centered. And we were looking at so many things from a profit standpoint and do more with less because we don't have enough people. But if we have too many people, then that cuts into our profit margin. So don't staff any more than you absolutely have to. And then you have to justify every single person that you have on the books who's not specifically assigned to a room. And it was just disheartening to think that you almost have these handcuffs on in terms of staffing because it might affect the bottom line. It might affect profit margin, might affect bonuses, all this other stuff. And it's like, I just want to be able to take care of patients. I want to make sure that we have enough staff so that our patients can be taken care of and that our staff are taken care of because they need the support too. And I think it gets forgotten that our staff need staff to be there to help out so that we have enough people. And you don't see that when you just look at people as numbers on paper. And that was that was a struggle for me when I was in clinical leadership.
I think that the hard thing for most nurses is when they switch to leadership is understanding that the business of healthcare has always been about money. And that was something that we were taught as nurses never to talk about, which was never talk about the money, never talk about anything that had to do with money, that money was evil and it was wrong. And so that we should always do more with less. And that our goal was, thank you for being nurses. It's so great that you have a profession that allows you to care for people. I'm sorry that we can't get you more staff. I'm sorry that we can't pay you more, but you do this job because it is in your heart and soul. But the truth is what you realize is when you get into the leadership, that is just a tactic that is used to basically expand on the goodwills of the nurses to keep doing with more with less and without understanding the business of healthcare. And it is something that we must change.
Yeah, I feel like it's an excuse to abuse and overwork is really what I feel like it is. It's to grab onto that, nursing is a calling, which is justification for working you too much and giving you not enough to work with, and you're going to do it anyway. And I'm not a big fan of that. So I have a question, though, because I've seen some of the stuff you've written on LinkedIn, some of the stuff you've talked about, and I want to make sure that we talk about it in this interview as well. But you have been working with a commission on nursing reimbursement, or I would like to hear more about that. Can you please tell us about it?
So I think before I can tell you about the commission, I think it's important that we talk about why the commission was formed, and that goes back into history. And so I want to step you guys back in time. And in the early 1900s, you got to know history so that we can understand this. Women had been fighting for the right to vote for nearly 60 years in the early 1900s. And the day before Woodrow Wilson's inauguration in 1913, the women's suffrage movement organized the largest march in the women's suffrage movement's history. And up to that date, nurses had stayed uninvolved with the women's suffrage movement. But in 1913, they participated in the women's suffrage movement march. And from that date forward, American nurses became highly involved in fighting for women's right to vote. It took another 7 years. And in 1920, women finally got the right to vote. But in the 1920s, what happened is that nursing became the largest economic vehicle for women's financial independence in the history of the world. And why that occurred was during the 1920s, nurses were able to bill independently for their services. Private families hired private duty nurses to provide them care in which they were paid. Hospitals at this time were deplorable places. Only the most destitute would seek care there. But as surgery started to get better, hospitals started to recognize that private families were bringing in private duty nurses and outcomes started to get better. So they started to employ nurses into hospital systems. And if you look back at all of the bills from the 1920s, you actually see a line that breaks out nursing services as a billable service. Nurses started to be able to represent their economic value in healthcare, but hospitals at the time were run by men. Physicians were men, and they started to feel that women had too much economic freedom and understanding about the financial model in healthcare. So in the 1930s, when the national development came to existence to develop a reimbursement or basically national insurance to cover healthcare in this country, the men that were running that were looking to create a model that would capture nursing services, but not directly give nurses a direct line of sight into the dollars they were earning. So they looked for a model that would capture nursing services. They turned to hotels. They saw that maids had been rolled into hotel room rates, and they rolled nurses into room rates in the 1930s. Forever hiding the value of nursing, placing nurses as the only profession that is a cost to healthcare systems. And what I mean by that is every other profession, OT, PT, physical therapists, physicians, respiratory therapists, all have a service that when they say, I did my occupational therapy, can bill for that service. Nursing became hidden and was the only profession that is still 100 years later remains a cost to healthcare systems. So there is a misalignment between needing more nurses and understanding that hospitals are going to staff nurses to the lowest cost denominator in all situations because it costs hospitals the same to basically staff nurses at 1 to 4 to 1 to 8. And the truth is they make no money and any difference along those lines. And fundamentally, what we've started to realize is that in the business of healthcare, the situation around nursing is never going to be fixed, not with another meditation app or more yoga or telling nurses to pull themselves up by the bootstraps. The only way we're going to solve this crisis, and anybody who's been in business is going to be for it, if you don't have a way to pay for something, there is no business model. So the Commission for Nurse Reimbursement was founded in May 2023 with nursing and healthcare leaders from across the United States in an effort to develop a reimbursement model that will take nurses out of being a cost, take them out of the room rates, so that we know that more nurses have a reimbursable service so that we can align correctly the right number of nurses needed to sustain healthcare on a go-forward basis and fundamentally support the economic model around nursing.
So is this going to be a different billing system, you think, for each level of care? Because, the ICU versus med-surg, those require different nursing
It's a great question. So we have about 7 models in development right now by our economic team who saw the world very differently, agreed that there had to be coming out of the room rate. So some of them, to your point, is like very similar to OTPT. Depending on the acuity level, you'll be reimbursed for 15 minutes of direct nursing care within an ICU level, which is a reimbursement code of X. Others have other ones that have other ideas that basically tie outcomes for reimbursements to hospitals to say, look, if hospital outcomes are better on these 7 metrics, they get access to additional funding resources that tie directly back to nursing services. So we're coming forward with a host of solutions to say, look, we don't believe that this is going to drive up healthcare costs. In fact, one of the most things in nursing that we've never done is we always stop at outcomes when it comes to the impact of nursing homes, but we've never tied it to the economic dollars within healthcare, right? Like, so this amount of mortality, this amount of infection leads to X amount of dollars. What is the impact that nurses have on actually saving those costs? But more importantly, where are they actually making money for hospitals based on fines and certain things that are prevented by the work of nursing workforce? So stay tuned. We are about 7 models coming away, but I can't believe how fast it's been moving. And the truth is I think people recognize, any business person that you talk to and immediately explain that nurses are a cost to healthcare systems, they immediately get why we can't staff nurses to the right cost denominators. And most of the state senators that we're talking to, the state treasurer's offices who are reaching out to us on this also are saying, wait a second, we've been sending billions of dollars to our nonprofit healthcare systems. Where is all of this money gone? Why do they keep cutting nurses? Why are they telling me that they can't staff nurses? They had no idea that nurses were a cost to healthcare setting. And so every time they send dollars to these hospitals, those dollars are not being earmarked to support nursing workforces. And as the example in North Carolina, $1.75 billion of state nonprofit dollars went and supported executive pay over the course of the last decade, not supporting the nursing workforce. And they had no line of sight that when they gave more money to hospitals, that was going to executive pay or to pay a new building and not underwrite and pay for the nursing workforce.
Wow. I'm just, I mean, like I can feel that because I can think about my own career. And one of the reasons that I really loved moving into the OR was because I knew that I had one patient and I could focus on one patient at a time, every single case, instead of my med-surg experience, which was horrific because I might have 8 or 9 patients on a shift, on a 12-hour shift. And that's too many to have at one time, especially as a more inexperienced nurse, because this was young, earlier in my career. But then if somebody didn't show up, I got both halls. And so suddenly I'm responsible for 16 patients. And if the other, LVN that was staffed with me was there, I was still responsible for all 16 assessments that day, on top of everything else I had to do. And it's just too much. And then to think that nursing is simply just seen as a cost or a drain on the resources of the facility. And when you look at it financially, it's kind of demoralizing, I think, to think about our service to patients and our care of patients and our service at the hospital seen as simply a cost and not a benefit to our patient care.
Well, and even when we transition to that, the average, experience of a nurse is what did you say, 2.6 years, I believe. So how, with all of these problems that we're facing, and granted, there are so many advocates like you and all of your partners on these coalitions to make it better. But in the meantime, how do you encourage people to stay the course, to stay in nursing, to fight the fight and convince them that in the end, it's worth it? Yes, we get into healthcare because we want to take care of people. We want to make things better. But at the end of the day, there is a line, right, of things that we can tolerate. How do you encourage people without towing the company line to continue to do that?
I think we all as human beings have to make choices within our careers on what is our breaking point. And I think that's different for everyone. And I think nurses have tolerated more than the rest of just being told that this is just the way things are and it's the way that they should accept them. But I think things are changing, and I think it's time that they do, because at this time, I would not tell any nurse to stay in a situation that felt abusive or discriminatory or unsafe to be. Because the truth is, the only one who is going to lose in that scenario is going to be the nurse. And the truth is I'm almost at the point where, as much as I know we want to not abandon our patients or abandon our friends at the bedside, the truth is there comes a point in time where either we must stand up and fight for that. And that means you're either unionizing, you're walking out, or you're quitting at scale to actually say, I'm sorry, but these systems are not functional in the way that they are, and I cannot stay. So I don't want to sit there and tell anybody you have to grin and bear it and stick with it. I actually think it's come to the point that we've done that for long enough. We did it through the pandemic. There was no PPE. There was no treatment. There were no vaccines. We were written up for wearing masks. We were told that we were endangering patients and creating paranoia when we did that, which we know is all completely false. Nurses died at the highest rate of any kind of healthcare professional in those situations. We endangered our loved ones, our families. I know my own care of my friends and families who went out and came home infected and then infected loved ones who never saw the light of day again. Those kind of things bear witness to how we have been selfless time and time again, and it is time that we are finally selfless for ourselves. So what I would say to you is, if you are not ready to give up on nursing, and the truth is I'm hoping you're not, what I would say to nurses, though, is that you need to start understanding how you have to actually organize and be effective with those voices. And the truth is, it means we're going to have to get uncomfortable. In fact, Florence Nightingale said in her journals written in the 1870s, she said it was going to take 150 years for the world to recognize the world she envisioned for nursing. 1870 plus 150 is 2020s. This is our time to define it. And I don't think change comes easily. I think change comes because you have to risk things. It means that you're going to risk yourself, your career, and your reputation to fight for this profession. And I think that is exactly where I am within my career, and where I think many nurses who have been there long enough are saying, you know what, I am not going to tell the next generation that they have to stay. In fact, I'm going to tell them how they need to advocate for themselves. And then those of us who can are coming together on social media, on LinkedIn, in places that we never would have gathered, and are putting light onto the darkness that we have kept hidden for so long, because we must drive those changes. So if I can tell you anything, you're getting ready to burn out because of it. To me, that means you just need a change of scenery, go somewhere else, but do not give up on nursing.
Melanie, I think from a podcasting world, who I hope hears this isn't necessarily, obviously another nurse or healthcare professional, but who I really hope hears this is patients. Because I would hope that a patient could advocate and say, like, they want to know that their nurse can have the time, can have the say, can have the wherewithal, to be able to care for them the way they want to be cared for. And advocacy, not only do we have to do that from a patient standpoint and a healthcare standpoint, but we also do that for ourselves. So, goodness, this is eye-opening, not just for other healthcare professionals, but for those who need the services of those people.
Yeah. And I have to say that I'm listening to you talk about what the state of nursing is. I know we didn't actually address it, but I know you use that hashtag all the time, hashtag state of nursing. And it's not a great state right now, just to be as honest and raw as possible. But there is hope to change it. And we change it through advocacy, through, like you said, raising our voices and making it better through legislative action, through unionizing, all the different ways that we can do that. But there's hope. There absolutely is hope for change. There's hope for making it better. And I'm excited to see what comes through the work of this commission, how you're able to bring that about, because it's a novel idea to me to think of being able to bill for nursing services separate from just the collective hospital bill. I don't think that I ever would have thought of that as something that we could do. But
imagine how great it would be, and what would nurses could do if we could actually bill for our services at scale through insurance, right? We would all run our own companies, right? We would all go back and take care of patients, do the things that we know we're good at, and manage it. And the truth is, we're seeing those grow right now, right? Concierge nursing services and practices are growing across the United States at scale. People are willing to pay for them. The wealthy are willing to pay for them. We see Navi Nurse. We see On-Call Light. We see all of these nurses starting businesses that they're not using insurance, and people are willing to bill for them at scale, because the truth is, those people know the value of nursing care. They know it is the nurse who keeps them alive, the nurse who nurtures them back to health, the nurse who recognizes the change in status and makes sure that the doctor does the procedures and the treatments that are necessary to advance their healing. That is what our superpower is. And it is time that we bring this back. And that the truth is that our systems who basically benefit at keeping nurses as a cost onto those dollars into room rates, those ones that are able to make the millions in dollars in executive pay at the top of our nonprofit healthcare systems, that those dollars are actually tracked to make sure that the amount of community care and nurses are at those places so that we are driving to the patient. And the truth is, this is at the expense of all of us. We are the taxpayers who pay this. And it is the role of government to protect the people, where it's always been about business to protect the profits. And somehow too much of business has gotten into healthcare that has not made it about people any longer.
Wow.
True.
I've got
What a great way to end it.
I need to like, get out my little streamers and start shaking and clapping and celebrating. But I just, these conversations go by too fast, and we don't ever have enough time to capture everything I want to get in a conversation. But this has been eye-opening, and it's a great conversation to have, to begin having about nursing care, no matter where we find ourselves in working in the healthcare sector. We need to be aware of what's going on and learning how we can advocate for our profession. But before we go, Rebecca, I want to give you the mic one more time. Is there anything else that you would like to say, to any advice you'd like to give, or any final thoughts before we go?
Well, Melanie and Chris, thank you so much for having me. And I just would like to share with anybody who is listening that I don't believe that there is a greater profession in all of healthcare than nursing. And I can't imagine a world, and I can't imagine the United States without nurses, because they are the ones who always run to the accidents and the patient in trouble and the person in trouble and the neighbor in need and the family member who needs it. And it is part of the moral fabric of our society that the world is better with nurses in it. And we in the United States should be doing everything we can to preserve nursing, because who are we going to become as a nation if we don't have them? So that would be the message that I leave. And everybody who is a nurse on here, you should be so proud of who you are, because to me, there still is not a profession that deserves greater recognition, applause, and support than nurses. So thank you guys for having me.
Thank you so much. This has been a fantastic interview.
Really has. We really appreciate you. Thank you, Rebecca.
That was Rebecca Love, Chief Clinical Officer at IntelyCare. And Chris, I have a lot to process now after this conversation. So much information, so much truth, and so much of the reality of what nursing care and just healthcare kind of has become. Rebecca really left me with a whole lot to think about. That's for sure.
Well, and we have, I think the mid-level provider is the key to our United States healthcare system, right? Like, we're seeing more nurse practitioners, more CRNAs, more PAs, but I also think that it's what it's leading to is the trickle-down effect, where we're also seeing more health science and allied health professionals, more support teams, and then different levels of nursing too. LVNs, ADNs, BSNs, and everybody needs a voice. Everybody needs a seat at that table, and they have a right to demand that they can offer their services at a quality level. And I love that she's advocating for that.
Yeah, absolutely. And she definitely has the platform to do it. I would encourage any of you listening to check her out. You can find her on LinkedIn. That's Rebecca Love. Look for her profile on LinkedIn and eat up all of the information she has on her page. I promise you will not leave uneducated, because there is so much there to learn. But that is going to do it for this episode. So on behalf of Chris, myself, and the whole team here at First Case, thanks for listening to this week's episode.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app, or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts, and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.